kick. Hello, good afternoon. Welcome to Dr Steevens Hospital for the weekly press briefing. Could I ask the speakers to introduce themselves from the left?
Damian, McCallion, HSE National Lead for Vaccination and Testing and Tracing.
Colin Henry, Chief Clinical Officer, HSE.
Anne O'Connor, Chief Operations Officer.
Paul Reid, CEO.
And I'm Mark Brennock, National Director of Communications. I'd like to welcome Bernie and Susan, our Irish Sign Language translators. This briefing has been broadcast on the RTE News channel and on the HSE Live Twitter feed. And could I first ask Paul Reid to give his weekly update?
Good afternoon, everybody, and thank you, Mark. The confirmation that Omicron variant has been detected in Ireland, I suppose, probably comes as no surprise to anybody, and we're all waiting further and more complete information on its transmissibility, ultimately its impact and seriousness in terms of hospitalisations, etc., and how it responds to vaccines. And it's frustrating for many that another variant emerges with some uncertainty again. But I think, as we've always said, that's the very nature of COVID that we've been dealing with for the past 20 months or so, in terms of the unpredictability. And any time we think we can predict what's ahead, it comes back and surprises us again. But from a HSE perspective, our obvious and immediate concern is its potential impacts in terms of hospitalisations, sickness levels, indeed ICU or mortality, particularly as we head into the winter, heading in with high levels immediately of the COVID patients. Just want to say in the first instance, between the hospitalisations and ICU numbers certainly have stabilised over the past week in particular. However, they stabilised at an extremely high level. That still poses a huge risk for us as we head into December and as we head into the winter period overall. And there's no doubt there's a couple of key actions that have happened that have supported that stabilisation over the last 10 days or so. And the first and most prominent one is definitely the actions, public health actions taken by the public over the past couple of weeks. Again, I want to thank the public. The individual collective actions that the public are taking are making a very real and immediate difference in terms of the risk levels in our hospitalisations and the risk levels in healthcare overall. And secondly, a range of actions that we have taken ourselves, which I'll come to in a moment, to de-escalate what was and has been and still remains a very volatile situation in our hospitals overall. So we're still far from out of the woods on all of this and the impact it's having on the healthcare system overall. And we will need to sustain both the public actions and indeed our own actions that we've taken for some time to come. Another first line of defence that we have, along with the public's actions, are certainly our vaccines and the booster programme overall. And I know that everybody's really anxious to see boosters rolled out to everybody, and there's nobody more anxious than ourselves in the HSE, and that's what we are planning and that's what we're aiming to do. The speed of rollout is obviously a function of the timing and prioritisation of the various groups as set out by NIAC, but also in terms of the eligibility criteria for the 5-month criteria for the various prioritised groups as they come through. Interestingly, just to note, Ireland is now in the top 5 of the EU countries for a rollout of boosters per head of population as of today. Last week alone, we completed over 214,000 vaccines in total across the programmes. And as of yesterday evening, there are now 880,000 boosters and third doses administered over the past few weeks. Interestingly also, in terms of very positively, we're also seeing continuing presentation of people for their first and second doses. Last week alone, we completed just about 10,000 dose ones and over 10,000 dose twos in the population. And this is a really important part of the protection. So while a lot of our focus is certainly on boosters and third doses, it's really important, particularly as we analyse and demonstrate the impacts on quite significant impacts and disproportionate impacts of unvaccinated population on the healthcare system overall. And if you just stand back and assess that, the vast majority of people, adults, the vast majority of people with COVID in our hospitals are adults, primarily over the age of 18. And if you just stand back and assess, just about 6.5% of the adult population aren't now fully vaccinated. So 93.5% of the adult population are fully vaccinated. So those who are unvaccinated are highly disproportionately represented in our hospitals. If you just look at the current state position in relation to that, 48% of the COVID patients in hospital now aren't fully vaccinated. 50% of the COVID patients in ICU now have had no vaccination at all, and 2% are partially vaccinated. And interestingly, in the age group of 19 to 14 years of age in hospital, COVID patients in hospital, 79% are not fully vaccinated. So these are really high, disproportionate impacts by not being vaccinated, impacts on our health system. So notwithstanding our focus on continuing our communications on the booster and third dose vaccines for the immunocompromised, we remain resilient to try keep still working through those who have not had a vaccination. And my message again today is please do come forward. We've always said nobody will be left behind. Just on our hospitals at the moment, we now have 547 positive COVID patients in hospital, which is down about 8% on last week. And over the past 7 days, there have been 345 admissions of COVID patients to hospital, which is an average of about 49 per day. And in the 14 days to the 1st of December, 506 patients have been hospitalised to date. Of the 506, 40% are age 65 and over. About 40% are aged between 35 and 64. 13% are between the ages of 19 to 34, and 7% 0 to 18 years of age. In ICU, as I mentioned, we have 117 patients now in ICU. It's certainly down 11% on this day last week, and down about 2% on a couple of weeks ago. It is a welcome relief, but as I made a point at the start of my presentation, these are by no way, by any standards, can ever be judged as normal. These are highly disproportionate impacts on the healthcare system and still far too high. I mentioned at the start, we've also taken a range of actions ourselves within the health service to try mitigate some of the impacts of what we've been seeing over the past few weeks. And last week alone, we've utilised almost 1,500 bed days from the private healthcare system. And that includes 70 bed days last week for ICU. We've utilised an average about 11 ICU beds from the private system. To date, over 17,500 public patients have received treatment through the agreement that we have with the private hospitals. And very positively, a very significant proportion of the activity over the past few weeks in private hospitals has been utilised to address some of our waiting list activity, some urgent care that's needed, but on our waiting list. And we're anxious to mitigate the impact on waiting lists, obviously, during this period, but obviously impossible to mitigate the full impacts. On our ICU and surge and preparations, we've taken a range of actions. Currently, 40% of ICU capacity is assigned or taking up with COVID patients. We're continuing to work with the hospital system overall, and particularly our intensive care consultants, to build and continue to build surge capacity. We know that from previous waves, a level of safe care that we can surge to beyond the level, though, after that, it's not as safe. And last time we brought that up to approximately 350 beds in our surge capacity. And we're aiming to do at least that and possibly more. But again, we're still working that through with our ICU teams all across the country. A range of other measures that we've been taking over the past few weeks, primarily part of our winter plan, includes increased GP access to diagnostics, availability of more home care, putting in place more acute and community beds and step-down beds, community intervention teams, focusing on delayed transfers of care, and a range of actions in our community services. On resourcing, we are, again, just to make the point, under extremely and unforgiving demands on our healthcare system, particularly at a staffing level. GPs and their practices are also going through unprecedented demand levels as they head into winter. From a HSE perspective, we're resolutely working to stabilise and increase our resources across the system. And And these include, as I just mentioned, our resourcing for our ICU and surge, for our community services, trying to resource further our testing and tracing programme that's under huge demand, and indeed resourcing up a continued scaling up booster and vaccination programme, which my colleague Damian McCallion will bring you through shortly. However, it isn't simple, and these resources aren't just waiting out there for us to tip them on the shoulder. It's not an elastic resource, and we are really aiming to get the highest level of resources we can. And I want to thank other sectors who are equally helping us along this way, and particularly the Defence Forces for their continued and great support. On our testing and tracing, again, Damian will bring you through some detail of this, but just to make a few points, over 223,000 lab PCR tests have been completed in the past 7 days. These numbers are just growing and growing, and I do remind everybody, we talk about the number, we are talking to scale up to 100,000 this time last year per week. We completed our highest daily community testing with over 27,500 tests completed in one day. And indeed, in one day alone, we had over 38,000 referrals, our community referrals coming overall, over 38,000 and 17,000 of those coming from self-referrals. We've put in place extra sites, testing sites all across the country, 6 extra over the past 2 weeks, fixed testing sites. And indeed, with the support for National Ambulance Service, we deployed 3 further pop-up sites to areas, particularly last weekend. On the antigen testing, just particularly for asymptomatic close contacts process we put in place, has been going on since 28th of October, as you'll be familiar. The numbers of close contacts referred through this pathway remain steady, an average of about 3,700 per day test kits dispatched daily over the past 7 days. And over 115,000 test kits have been sent out since the programme commenced overall. Just on antigens in schools, we commenced on Monday, 29th of November, as you'd be familiar, in terms of this process. And we have, on the first day alone, 10,000 antigen tests dispatched, and on the following day, a further 4,000. We did know that the first day would be probably a build-up of some cases identified late the previous week or over the weekend. Again, just in closing comments, myself want to thank the public for their continued support and actions and urge them to stick with it. We really need these actions to continue on a sustained basis. Secondly, we have obvious concerns about the Omicron variant, but let's await the further analysis and further evidence. Strong progress overall on our boosters, adding further protection. And again, my message to those who are unvaccinated, it is having an extremely disproportionate impact on our health system. Please do come forward. We are still there. And finally, we all have to remain confident, hopeful, but indeed cautious as we head into the Christmas period. I'm going to pass you across to my colleague, Ms. Anne O'Connor.
Good afternoon. We'll talk through where the services are at this week. So just in terms of people attending our emergency departments, that has continued to reduce this week down to just under 22,000. So you've seen quite a significant drop there in the past 2 weeks. Likewise, in terms of our attendances overall, that has also reduced down below the 2019 numbers. And again, 2020 is a different type of year in terms of data, so we tend to benchmark ourselves against 2019. What it tells us, though, now is that the reduction has gone on now for a couple of weeks, and we are down nearly 7% on last week in terms of attendances overall, which is up 7.1% on the same week last year, but down 9.1% on the same week in 2019. So we're actually closer now to last year's attendances than we are to the 2019 ones. In terms of our admissions, 2.7% down on last week, 7.8% up on the same week last year, and that's down 5.3% on the same week in 2019. So we've seen that continued reduction in attendances with people just not attending in quite the same numbers over the last couple of weeks. When we look at our over 75-year-olds attending, we can see that that has kind of levelled a bit this week, 2,755, and in fact our admissions have gone back up. So that tells us that the people who are attending, even though there are fewer of them, they are more acutely unwell and that they need admission. So back up to 1572 in terms of admissions. And what that looks like in terms of the last 8 weeks, we can see that we're pretty much the same as last week in terms of the attendances of people aged over 75. That's up 6% on the same week last year and down 9.5% on the same week in 2019. But our admissions are up 7.5% on last week. So that's quite a significant increase in the week. And that's up 11.5% on the same week last year and down only 5.2% on the same week in 2019. So we're seeing a kind of a changing pattern. And we can see, just interestingly, in the last 24 hours or so, we have actually seen a significant increase in attendances. So we're watching that. The attendances and certainly our trolleys, etc., had come down significantly, but we can just see a change in the last, as I said, last day or so. Our patient experience time overall improved, related presumably to the lack of attendance, or the reduced number of attendances. In terms of our 24-hour patient experience time, that's for everybody attending the emergency department. Our 9-hour patient experience time improved also just by 1.9% on last week. And that is now at 59.1%. So again, as I keep saying, that's a very important metric for us to manage in terms of how long people are in our emergency departments awaiting admission or to be discharged home. Our trolley count, so as of 8 o'clock this morning, we had 256 people on trolleys, and you can see that that is a significant increase on yesterday's number. Our average over the past 7 days is 179. So that increased attendance in the last day or so showing up there. And our detox, or delayed transfers of care, still in there under 500. So we're managing the delayed transfers of care. So in terms of that patient flow through our hospitals, supporting people in terms of discharge, we are continuing to focus on that and ensuring that we are not losing too many bed days to people who could be at home or in another facility. Just Paul mentioned the COVID-19 numbers there. So 547, as he said, which is down 9% on the same day last week, and a significant increase, obviously, on the 25th of June when we had our lowest number of 38. And our admissions in the last 24 hours of 43. Our overall admissions for the last, or the daily admissions for the past 2 weeks, just showing up there. So you can see it's kind of come down a bit and trending down, and likewise our ICU admissions down a bit too. Just one slide I want to draw your attention to relates to our ambulance activity here. So we can see, and again, it's probably a hard enough one to see, but certainly in terms of what the data is telling us, that top red line. So when we look at the normal tracking, you can see the green line in the middle is what we project as our ambulance activity. So that is, and our ambulance activity is normally very accurate. So we use this as a benchmark every winter in terms of looking at the activity, the projected activity for the ambulance service, and that gives us a good indicator around all of our unscheduled care activity. We are concerned though, because we can see that the activity in terms of the ones on the left there, so that is our calls in terms of the actual instance activated. And the one on the right is our transport. So these are the people who are brought to hospital by ambulance. And you can see there on the chart on the right-hand side, that is sitting significantly above any projection. So it is way outside of what we expected. And worryingly, when you look to the right of that chart, you can see that very steep rise there at the end of December. So if we continue to work so much higher than our projected level, when we get to the end of December, we will have cause for significant concern in terms of our unscheduled care activity. So we are watching that, and certainly our ambulance activity is very, very high. And we see that in terms of just the number of people who need fairly acute admissions to hospital. Just in terms of some of the other ambulance service activity, we have invested in the last year or more on some hospital avoidance initiatives in terms of Pathfinder, putting in a clinical hub in our control centre, and having community paramedics, etc. And so those 5 initiatives there make up our hospital avoidance pathways in terms of the National Ambulance Service. And across those 5 initiatives, we had 450 calls in the past week. Now that's nearly 21,000 year to date. Of those, 186 were provided with an alternative pathway. So rather than just calling an ambulance and being brought to hospital and admitted, these people were given a different pathway, either through a Pathfinder, so for example, people going out to their homes, or being triaged differently through clinicians at our control centre, etc., or having community paramedics call out. So that means that year to date, we have nearly 10,000, so 9,550 people who were given an alternative pathway and did not need to come to hospital, versus 11,277 who did need to be brought to the emergency department. So these initiatives are the types of things that we are developing as part of our winter plan and our service plan next year. Again, all with the purpose of reducing the numbers of people who need to attend emergency departments. So people who can receive treatment at home through different types of services, so be it paramedics, doctors, allied health professionals, etc. So these are very important initiatives, and we will continue to expand them. Paul mentioned the private hospital activity. So in the last, this week, 1,375, and continuing to focus on that in terms of giving that critical capacity to our acute hospital system. And I just wanted to mention home support. So we've had a significant, I suppose, interest in home support of late. And just on the left-hand side of that chart there, you can see that going back to January of last year, we had nearly 8,000 people awaiting funding for home support. So our key issue last year for most of the year was about not being able to get approved funding to support people to go home, etc. And the numbers of waiting carers were actually very low. So we had about 1,300 nationally at that time. You can see there, as of October of last year, that graph crosses over. So actually, the numbers now awaiting funding have come right down nationally to only 310. And that's not really a waiting time. That's just a kind of a process time, if you like, in terms of quite a small number of people who are awaiting home support funding approval. However, unfortunately, what we're seeing is that the number of people awaiting carers has gone right up to nearly 5,000. And that is a cause of concern for us, because this relates to people who are either at home and not able to receive home support funding to keep them at home, and they will eventually end up needing additional supports, for example, in our hospitals or nursing homes, or people who are in hospital who can't be supported to go home. And again, this is very important to us in terms of supporting that critical patient flow as we head into the most challenging time of the year. There is a lot of work going on to try and improve this situation in terms of having more access to carers, but unfortunately it is proving to be very challenging, and we just don't have enough people coming forward to work with us, or indeed to work with funded agencies as carers at the minute. So I just want to flag that, because sometimes people think it's a funding issue. It's really not. In terms of people being delayed now for home support, it is about access to carers. And unfortunately, it is a situation now that is arising all around the country. It used to be confined to a couple of areas, but it is now much more widely spread. Just want to talk about an initiative that we're launching today in terms of grief and bereavement. And this comes from a bereavement support and communications programme that was established as part of the response to COVID. We've been working very closely with the Irish Hospice Foundation, and I just want to acknowledge their work and a range of partners in terms of looking at people's experiences of death, dying and bereavement. And this is really important, because we know that during COVID-19, in the last 18 months in Ireland, we've had approximately 45,000 deaths for all sorts, just normal deaths across the board. Research from the US tells us that for every death during COVID times, there are about 9 people impacted. So if we look at that in Ireland, that equates to over 400,000 people potentially impacted by bereavement in Ireland in the last 18 months. And what's important here is that COVID has hugely disrupted people's ability to respond to bereavement, and unfortunately, people's ability to grieve in a normal way. And in Ireland, we have lots of traditions in terms of bereavement and grief around funerals, etc., and interacting. And we know from the research now that people have been disrupted in so many different ways: ability to travel, ability to attend funerals, to mix funeral parlours, etc. So we have now developed this initiative, and we want to just let people know about it today in terms of the work that has gone on. And people now will be able to find significant information on our HSE website. So we have now got a grief section on the HSE website, and we encourage people to go to get more information on grief. So the important thing for people to know is that there is no one response to grief, and everybody needs to look at how they are. People grieve differently, and some people struggle for long periods of time in response to bereavement. So we encourage people to go to our website to get information on grief and on bereavement. And we have also established a bereavement support line run by the Irish Hospice Foundation that operates now from 10 to 1 every day, Monday to Friday. So this is a really important initiative, and I'm sure we all know people who have experienced loss and bereavement in the last 18 months, and we encourage people to attend or to access this website and access the information and supports that are now available. We will also be developing significant supports for services and across our partner networks. And again, just to thank everybody, this is a really important initiative, and we're very pleased that we're now able to, I suppose, let it go live and have the information available to everybody. So just again, in conclusion, just to remind people in terms of some of the pressures across our health system and what we encourage people to do to help us to be able to provide care. to follow the COVID-19 guidelines, to get vaccinated, avail of testing and tracing appropriately, to look at flu vaccination. If you haven't been flu vaccinated and you are in one of the eligible categories particularly, please get vaccinated, and also to ensure that you focus on your own health and staying well. Thank you very much.
Thank you. I just want to go through the current trends we're seeing at the moment, which show a continual kind of picture of uncertainty, but some hope as well. Our 14-day instance at 1320, and we saw that peaked at its highest back in January, when of course we didn't have vaccine coverage and protection as we do now. The 5-day moving average is dropped a little from last week, but still a very high level of community transmission, 4,477. Hospital admissions have dropped a little, 547. Still very high number of patients with COVID, although who need care in a special environment. And ICU admissions down a little, 117. And we still see, of course, patients outside intensive care units receiving enhanced oxygen or non-invasive ventilation, which underlines the strain that this virus is having on our healthcare system, or indeed right across Europe. So new cases of COVID-19 risen in the month of November from a weekly average at the start of September of 1493 to 4538. And as I said, hospitals were low in September, 311, beginning to fall a little bit now, but considerably higher. And of course, ICU, a particular pinch point. And what we see here is as we've said in recent weeks, that all parts of our healthcare system, from primary care, from testing and tracing, from public health departments, emergency departments, intensive care units, community services, all under considerable strain, not just from COVID, but from the whole range of winter viruses and the continuity they're trying to maintain in other essential services. So looking at the age group, what we're seeing is a trend now, which is certainly a cause for hope, which replicates what we saw in Israel, which is, of course, is the country at the front in terms of administration of the booster vaccine. We're seeing falling cases. If you look at that graph at the bottom, falling cases in those older age groups dropped 14% in the 85 plus, almost 20% 75 to 84s, and 8% in 65 to 74. So a dropping number of cases in those over 65, and as you go upwards in age, an even greater drop in cases. While we see that shift to the left of the cases being detected higher in 0 to 18 years age group, and just beginning to even out in those other age groups. So we're seeing a falling number of cases in those who've had access to booster, particularly in the very elderly age group. And what about hospitalizations in ICU? We've always seen this differentiation between cases and harm. And the harm is certainly slanted towards those who are older, those with underlying conditions. And similarly, hospitalizations in 65 to 74-year-olds accounted for about 17% of total hospitalizations. But again, look at that table at the bottom, the sharp drop, albeit over small numbers, but the drop in hospitalization of those in older age groups. And we know from the Israeli studies, the booster vaccine led to a sharp drop in hospitalizations in those who received the booster vaccine, which should give us great cause for hope, especially as we get right through those critical groups. Residential care residents almost completely finished, those over 80s almost completely finished, and getting through large numbers of healthcare workers and those in those other eligible groups. That story still remains, though, that the unvaccinated, a small part of our population, but rather than talk solely about the impact they have on healthcare services, the personal risk too for people who are unvaccinated, a much greater chance of being hospitalised should they get COVID-19, and a much, much greater chance, 11 times more likely to be admitted to intensive care units. Of course, this goes with those who are unvaccinated, who are older, those who are unvaccinated with underlying conditions carry that much greater risk, that 11 times on top of an existing high risk that they're carrying already. But the personal risk is considerable to people who are unvaccinated at a time when there's huge amounts of virus in the community, which drives its way like a flood through the path of least resistance, that being unvaccinated cohorts. Outbreaks, 10 outbreaks in nursing homes, relatively small numbers associated with compared to back in January, and a much lower degree of harm when compared to those outbreaks we saw in January, when we saw 7 or 8 per day. Likewise, in hospitals, we're seeing relatively low numbers of outbreaks, not just happening because of vaccination, but also through the huge work of healthcare teams in infection prevention control, the donning and doffing of PPE, of course, the frontline healthcare workers embracing the vaccine with such enthusiasm, and now, of course, in the same way, they're embracing the booster vaccine in huge numbers too. And we're seeing that despite those big numbers of cases, almost at a parallel what we saw in January, the harm associated in terms of what happens in the healthcare facilities. On the left-hand side, the hospital-acquired cases, we'd like to see very few, but there's still very small numbers compared to January, when it was running riot through our hospitals. And despite the efforts of everybody, we had no defence. The vaccine did not offer that defence that it does now. Outbreaks have risen in recent weeks, but much lesser degree of harm associated with them. On the right-hand side, the number of healthcare workers who are acquiring COVID in the most recent measured week is down to 307. Did peak just over 400 a few weeks ago, but there's positive trends there too. And again, the outbreaks, this graph shows the outbreaks in different surges. And you see on the right-hand side, a longer, more protracted, but low-level number of outbreaks in hospitals, community hospitals and nursing homes. And as I said, associated with a lesser degree of harm. There's been much commentary on the rise, and it is a troubling rise in those aged 0 to 18 years of age. And thankfully, it is, for the most part, not a cause of serious illness among children. Serious illness warranting admission to ICU is relatively rare among children. Of course, if enough children get sick, and enough people get sick, even if a very low proportion become seriously ill, eventually you will see cases being admitted to hospital and in intensive care units. This graph shows that when we open the schools, if you look at the purple line, that's the 5 to 12-year-olds, and the opening of schools led to a bit of a bump in the first few weeks, then it steadied out, and then easing of restrictions for society came in mid-September, 20th of September, I think. What we saw, the line missing from this graph, is adults rise first. That 18-plus age group rose first, followed by that purple line, which was children. There was a lag effect there, and suggesting what is the experience of our public health teams in the field is that children, for the most part, acquired this virus in the household setting from adults rather than brought it home from school. It's not to say that schools are sterile settings, that transmission can't occur there, but the overwhelming experience of our public health teams, given the controls in school settings, is that the surge we're seeing among children followed a surge in adults following reopening of society. So where are we in relation to other countries? There we are, just falling down that table a little bit. We see, but what's really become more important in this 14-day instance is what's the harm associated with that, and I'll show you in a second what the latest is. So the ECDC current level of concern unchanged from previously 8.3 out of 10, which they mark as very high, and they base this assessment on 14-day instance, weekly hospital admission rates, weekly ICU rates, and death rates. So a note on the Omicron variant, first detected in South Africa only a short time ago, reported November the 9th, reported WHO November 24th. WHO declared it a variant of concern very shortly after, and we go into why that is the case, November 26th. 44 confirmed cases in 11 EU countries, November the 30th, and the first confirmed case in Ireland, December the 1st. And we know there's a large amount of mutations in that famous spike protein, between 24 and 34 mutations that around the area that suggests that this may be a more transmissible version, and one that may carry additional resistance to vaccination, but that has yet to be proven or yet to be demonstrated in the field. So the ECD assessment looks at those. What is a variant of concern? Something that's more transmissible, something that is resistant to vaccines, something that may suggest a risk of reinfection, and something that a virus that has other properties. So there's considerable uncertainty around these criteria, but there's certainly those mutations suggest that a potential for escape against vaccine-induced immunity, a potential for escape against natural infection-induced immunity, and a potential certainly for transmission advantage, so much so that the ECDC have reinforced their concern over the emergence of this particular variant. And the WHO, likewise, they look at the similar profile of what constitutes a variant of concern, what it means, and the transmissibility. Some suggestions based on the mutations in that spike protein and the behaviour in South Africa suggesting it's more transmissible. No evidence to date that it's a more severe disease. That's going to take time, I'm afraid, for us to find out. Effectiveness of vaccines, that's work underway. Again, too early to say. Some of the mutation markers suggest it may well be. Effectiveness of current tests, the widely used PCR tests continue to detect infection. There may be increased risk, as I said, of reinfection, and existing treatments for severe disease such as steroids still effective. But again, we'll be learning on the field, and not just in this country, but from other countries, on their experience as these people present. And for those who become ill, what their profile is, what their vaccination status is, and how they respond to treatment. And there we have the variants, the confirmed cases around the world in orange detected from a traveller, and the purple in local transmission, which seems to be congregated in South Africa, but we see cases now detected across the world in many countries, all with travel association, including a single case identified to date in this country. Vaccinations continued high uptake, highest EU area for ourselves, remarkable uptake right through age groups, including right down to age groups that have very little to fear from the virus, but nevertheless we've seen embrace the vaccine in huge numbers, and that includes 18 to 29-year-olds, 85% now fully vaccinated, a remarkable figure, and for 12 to 17-year-olds, 72% fully vaccinated. And Damian, who's will speak after, will elaborate on this. We see huge uptakes of the booster over 80s, 85%. 70 to 79s were 3/4 way through against what we know to be eligible. We're heading right through the 60, 69-year-olds, well over about 480,000 in that cohort. Residential care facilities who are younger, 61%. Healthcare workers, now 2/3 way through them, and the other eligible groups who will be coming on in December, namely the younger age groups, and going down right down to the groups prescribed by NIAC. So what has been the impact of this booster to date? Well, here's some early figures from Ireland, which really replicate the Israeli experience. And this shows that we see those 5-day average percentage changes dropping in those age groups. If you look below that dotted line, the dropping cases in 85 plus the 65 to 74s and the 75 84s, all dropping, coinciding with the booster campaign. And again, suggesting what's been seen internationally, that we see a sharp drop in cases, and hopefully to follow the harm, the hospitalizations, of which I mentioned earlier, we're seeing an early trend in this country. Some across Europe, COVID-19, some data coming out from the Eurosurveillance EU shows that vaccines have saved nearly 9,000 of lives aged 60 and older in Ireland, and Ireland, of course, having the highest vaccination rate. And this, yes, the immunity wanes. Yes, a booster campaign is necessary. That doesn't mean they didn't work. That does not mean they didn't save lives. That doesn't mean they prevented our healthcare systems from becoming overwhelmed. The vaccine program to date has been extremely effective in preventing serious illness, hospitalisation and death. And around Europe, we see a comparison of case numbers, hospitalisation rates across European countries, high vaccination rates. If you look at the left, there's a correlation of the number of cases per 100,000, high vaccination rates associated with lower cases and hospitalisation. And you can see on the right-hand side, Ireland, UK, low hospitalisation occupancy and low average number of cases. There's a strong correlation in country level between vaccine uptake and hospitalisation and indeed the number of cases. I mentioned Israel earlier, that certainly a big drop following the booster campaign. It began at the end of July. Case numbers have been rising, but since August you can see a steady drop in age groups right across the demographic, which should give us great cause for hope. At the same time, as Hans Kluge said, Europe is the epicenter of this pandemic, and we see the harm particularly associated with that in Eastern European countries, those with low vaccine uptake. And some countries now reintroducing some controls in addition to vaccines, in addition to all the other measures, reintroducing some controls designed to curb the exponential rise of COVID-19. So final message: significant uncertainty remains about the potential transmissibility, the advantage of this Omicron variant, the immune evasion, how will it bypass natural immunity from infection or vaccine-induced immunity. Will it produce more severe disease? We don't know, and this all remains to be seen. Our own healthcare services, like many others across Europe, remain under considerable pressure due to numbers of cases of COVID-19 and associated seasonal viruses. Unvaccinated people, no protection from the virus. Vaccinations alone, it's a multi-layered approach. We know here and in other countries, it's public health measures as well as vaccinations will help control with this most recent Delta surge, and will help put us in a better position if there is a surge of cases associated with Omicron. Waning immunity necessary. We know that there is waning immunity with the vaccine. That necessitates a booster campaign for those aged 16 or older. And finally, a prevention of infection, which is relatively easy at an individual level, although the challenge for all of us is difficult and the ask has been hard, but it's much easier to do that at an individual level than the actual act of treating somebody who's seriously ill. Thank you.
Good afternoon, everyone. I'm just going to talk through initially just our testing and tracing, a brief update. There's been some discussion around the capacity, so I suppose I just wanted to paint a picture of where we've grown. Paul mentioned earlier the 100,000 being the bar some time ago, and when the disease first came into the country, we had very limited capacity. We were talking single figures in terms of thousands in terms of capacity. That was built up to 105,000, 105,000. By the end of October, that had jumped up to 147,000. This month, up to November, 220,000, 24,000, and by the end of December, further capacity will be introduced in terms of 245,000 testing capacity per week. So there's huge numbers there in terms of, and that's all been part of a structured surge plan that was developed many, many months ago through the team that have been working on testing and tracing, and indeed my predecessor, Niamh O'Byrne. So an awful lot of work has been planned out, and those steps have been taken to mitigate some of the pressures that we're aware of at the moment in terms of demand. And just again, some of the headlines: 1 million people tested in the last 6 weeks, over 200,000 swabs per week running through at the moment. And again, the average test per day increasing at all times. So there's huge numbers going through the system. We know there are parts of the countries from time to time on given days where pressures mean tests aren't available, but that does get refreshed over the day. And again, to reinforce to people, as capacity becomes available through the day, either through attendance or through gaps in the clinical priorities been released, those slots get released out to the system. And in recent weeks, we've introduced a number of sites that I'll come on to in areas where we know there's additional pressures. Just at a high level, I'm not going to go back through all of this in terms of the numbers. I talked previously, the clinically prioritised groups, which are those coming through from a clinical side or close contacts, over 90% of those, in around 90% of those are getting same day, next day referrals. And again, to reinforce the important point, if you have symptoms, and all of these people are symptomatic, you need to be isolating and restricting your movements until those symptoms are gone for 48 hours, irrespective of the test, either the appointment or the test result. So that public health message, difficult as it is really important for us to reinforce at all times. In terms of growing the capacity, the sort of steps we've taken, we opened 3 new centres last week in Athlone, Leopardstown and Swords, the current week, and last week Dublin, Cork and Shannon. 6 new sites on stream, bringing significant capacity, and many of those sites are growing their capacity week on week also in terms of what they're able to add to the testing capacity in overall terms. In addition, through various agreements and work with the ambulance service that Paul referred to earlier, we've opened up more pop-up facilities and more capability for both fixed sites, like some of the locations mentioned there around Tuam, Wicklow, Drogheda, Carlow, Navan and South Kildare, but also in terms of being able to support outbreak management with public health. So where outbreaks are identified, that mobile teams can go in, be it a nursing home, be it a factory, whatever the setting may be. All of those are a critical part of the overall response. And in the overall terms, between our testing and our tracing elements, over 2,000 people employed in that service, and many more also indeed contracted in outside those that we directly employ in the HSE. So just in terms of the close contacts and the contact management, again, because of the use of a lot of automation and trying to improve those processes, that has allowed us to grow the capacity. So although the positive cases over recent months, as Colm showed, increased, our contact tracing team have done phenomenal work to try and ensure that they maintain the figures. And just at the end there, you can see in terms of people getting the results when they get into the system, we're continuing to get those results out against our measures for both those that are detected and not detected. So again, the headlines, I won't go back around all of the numbers, reinforcing, I suppose, that people are in the main getting their results through in terms of the median times for both detected and not detected results, and the others simply reflect the pressures that are there in the system at the moment. Just moving on then to our vaccination programme, Colin has referred to the overall uptake, which you can see has been really positive around just the adult population there again. Paul referred at the start, less than 7% now, 6.5% left unvaccinated in the adult population. The measures, and I suppose what's allowed us to do that, so the primary programme we all remember worked through the ages, was very robust, used GPs, used pharmacies, and used our vaccine centres. We continue to offer that to people, whether that's through a pharmacy, referral through a GP, or indeed some of our vaccinator centres are still promoting walk-ins for your primary vaccination. And we're still seeing numbers, 2,100 in the last few days, even higher number in previous days. This is running much longer than we anticipated, and that's really positive that people are still getting the message. As Colin has articulated in the slides, the vaccination protects you, your family, and your community. And in terms of some of the other groups that we've worked with, that's included some of the high-risk groups, such as pregnant women, around ethnic groups, around counties or areas, and we've seen really good uptake in some counties where previously the level was slightly below the national norms. And that's through the work of our public health teams, community health organisations on the ground, and also where pharmacy have played a critical role there in providing easy access for people alongside communications and information campaigns. The walk-ins now have been strengthened up in terms of the booster programme, and you can see that over the last 3 days, that weekend, over 17,500 people utilised that walk-in facility. And again, we'll be continuing to try and use those in a structured and targeted way. But again, as I mentioned earlier, for the primary vaccination, those channels are still open to people if people check out hse.ie. So moving on to the immunocompromised, again, over 107,000 individuals identified, 86,000 doses administered, and all of the 107,000 that have been identified have been offered appointments. So many of those are still working through the system. Just briefly then on the booster programme, long-term residential care, all of those people over 65, substantially completed. We're working now, following recent NIAC guidance, through younger people who are in long-term residential care. And again, to reinforce the point, the programme is designed to run through the priority groups in sequence as best we can, while ensuring then that people are only called when they're eligible in the 5 months or 3 months as determined by NIAC. The over 80s, again, substantially complete, and although there's a gap there, there will be some people still coming through from GPs that will start to bridge that gap. But again, substantially completed in terms of the good work from general practice. And again, our home vaccination team supporting those people who can't go to their general practice to be vaccinated. 70 to 79s, again, about 2/3 of the way through, and our aim is to have all of those done by around the end of this week in terms of we'll get an appointment or early December. So really starting to make good progress. Again, general practice predominantly dealing with most of those, and that's again worked very well. 60 to 69s, many only became eligible through November, and again, good progress there, coming up now with close to 100,000 out of the 470,000, and they'll continue to be offered appointments and offered opportunities through walk-ins over the coming weeks. Housebound, I've mentioned, very important service. Again, to illustrate it, 2 vaccinators in a given day may only be able to do 5 or 6 people, but it's really important in terms of those people who can't get access, and there's a referral process there for GPs, and 530 people have had their booster vaccinated through that service. Healthcare workers, about 2/3 of the way through, and again, our aim is that the majority of those will either be vaccinated or will have the opportunity through an appointment or a walk-in by the end of December. Medically vulnerable commenced this week, substantial group just shy of 500,000. Already this week, 56,000 of those have been administered vaccines. And again, our aim is that the majority of those, alongside their eligibility, will either have been vaccinated, offered an appointment, or had an opportunity for walk-in clinics before the end of the year. 50 to 59s, again, we expect to commence that group around the middle of December in terms of our sequencing based on the NIAC priorities. And again, our aim is to compress and ensure we offer availability to those people before the end of the year. So in summary, between the booster campaign and third doses, over 880,000 people now have been boosted. NIAC have prioritised the risk cohorts. That's the sequence in which we'll work through, and that's really important in terms of the public messaging. We'll work through the groups in sequence, but we do have to factor in the eligibility as part of that process as well. Really good progress made to date in terms of the groups that I've just covered. And then the vaccination channels have been built up, the activity up to 215,000, give or take, over the last week. GPs working well, pharmacies starting to increase their doses and trying to increase that gradually week on week. Clearly, the Christmas period will bring certain pressures for primary care. We may see a slight drop off there, but again, plans in place with all the major GPs and pharmacies to increase that up again in the new year. And our vaccine centre is increasing the capacity available week on week using a mix of appointments and walk-in. Lastly then, in terms of planning on the recent NIAC advice, we're still working through that advice while awaiting further advice in terms of younger people, paediatrics 5 to 11, and the administration of the primary doses there. And NIAC advice will actually tell us that we can do that, but also will determine the relative priority, which will also drive into the time frame from when that starts. So while there's other factors, such as availability of vaccine, some of the operational considerations in terms of how those will be delivered, communication to parents, information, medical guidance, and so on, crucial will be the NIAC guidance and also where the determination of priority exists. So that's briefly where we're at with the vaccination programme. In overall terms, really good progress around the booster. As Paul and Colin referred to, really good uptake in relation to the primary vaccine, still seeing people coming through. And lastly, while we're trying to drive the capacity, we are still facing challenges on the staffing side. Anne referred to home care as just another area, I suppose, in our health system, but we're continuing to seek all possible sources there to increase the capacity. Thank you.
Thanks very much, Damian. Now we'll take questions. If you could identify your name and your media organisation, please. Yes.
Dimitri O'Donnell from RT News. A question for Paul Reid. You've outlined a sort of a semi-optimistic, I would say, outlook this week compared to last week. ICU numbers are down, admissions to hospital are down, but we have the looming threat of the Omicron variant, as we know. There's a lot we don't know yet about that. But are you concerned that the Omicron variant could undo some of the gains that we've seen, those modest gains in admissions to ICU, admissions to hospitals? Public compliance seems to be up, and that is having an impact. But how worried are you about the Omicron variant?
If we just hold the Omicron variant for a second, the numbers that have stabilised at the hospital level, but stabilised at a very high level, like 500, almost 550 people in hospital today with COVID and 170 in ICU. That's an extremely high level alone for us going into a winter period. So there has been some relief, but a high level. Specifically, our concerns now are heading into winter, obviously what winter brings and a flu season brings and the pressures that brings on the hospital system at those levels alone. And then thirdly, in terms of the Omicron, we all want to await the evidence and what emerges from it. Our concern would be particularly in terms of impacts on illness and hospitalisations. So if we were to layer on further hospitalisations, whether it's through Delta variant or it's through Omicron, that would put increased and significant demands on our health system at a time it's severely stretched.
In terms of the testing, there's been a few problems with testing and tracing, with people trying to look and book appointments this week, described by some people as very, very messy. They couldn't get their verification codes. You are scaling up. Can you take us through the numbers of when you expect to reach the 245,000? Because people are questioning, is the capacity there over the winter period to get to that 245, I think, 245,000 tests a week, which is a lot, isn't it? Do you have the staff to cope with that demand?
Specifically related to the testing?
Yeah, testing, swabbing.
The swabbing. Related to swabbing, we are now, as of last week, 215,000 swabs completed in a week. As we just outlined earlier, we're now testing per day 10,000 more per test per day than we were 6 weeks ago. We've scaled up to a level well beyond this 100,000 number that we started off to build from last week. And then the last 6 weeks alone, over 1 million tests completed. So we're continuously putting in more capacity. We put in 6 extra fixed centres over the last couple of weeks and extra mobile centres across the country where we've high areas of high presentation of the virus. So we've continuously scaled up. There is a point that this is not elastic. You just can't build it up and build it up and build it up. The first line of defence is exactly what we say, what the public adopt to public health actions. And we've seen really positive benefits from that. And the second point I would say, if you are symptomatic and you're awaiting your test, it's really important that you isolate and you isolate to at least 48 hours after the symptoms have gone. And the vast majority of people who are clinically referred are getting a test on the same day or the following day. So I'd urge people to urge with us, but the capacity we've built up has been phenomenal.
One last question. Certainly there seems to be some improvement. Would you agree that things are better than you would have expected, say 2 weeks ago, that the guidelines that have been introduced are having a positive impact, that people people can take some heart, I suppose, that the efforts that they're making every day to cut back their social contacts, to be more cautious when out and about, that is actually benefiting the health service. It is working.
Yeah, we'd like to publicly thank the public for the actions that they've taken, particularly over the past couple of weeks. They make a real difference, and they've made a real difference to our health system. It's de-risked it to a certain level, our health system, because we've now stabilised at a very high level of hospitalisations. But the actions the public have taken have really worked. Along with that, the actions that we've taken within our own hospital system and our community services to de-risk the hospitalisations have worked. Our the pressure on the hospitals have worked. So it's a combination, a strong combination with the public. What I would say to the public is we need to sustain this for a period of time. What has worked over the past 2 weeks needs to continue to work over the next few weeks. But I want to thank them publicly.
Hi, Simon Carswell with the Irish Times. Just on the booster programme, last week NICE said they recommended booster doses for the next priority groups, pregnant women aged 16 and over, and then the 40-somethings and on down. Can you give us any dates, Damian, as to when you might expect those to start happening? I appreciate they have to wait the 5 months, but even with that in mind, when do you expect to start those?
Yeah, we've done some preliminary planning, Simon. I suppose what we're waiting for is in terms of the paediatrics and just getting some decision making on that before we announce the dates around those subsequent groups. So we're clear in terms of the commitment to Christmas in relation to all those groups that I went through earlier, that people will either be vaccinated, have an appointment or the opportunity through a walk-in of those that are eligible again in terms of the 5 months. So there will be some people, obviously, as I said, I think previously, all of these groups are going to run for 5 months because anyone who's just been vaccinated with their primary second dose in the last week, clearly in 5 months' time will be there. But the bulk of the people, I suppose, based on the original programme, in those cohorts I referred to, we'll be making sure that they have that opportunity to be vaccinated this side of Christmas. That's our target, so it's a busy 4 weeks ahead. But in terms of committing dates, what we'll do is once we take stock of what comes from NIAC in relation to the paediatric side, we'll then come out with a remainder of our plan, I suppose, to see through the remaining groups.
So the priority is 5 to 11s after the initial...
No, sorry, but what I'm saying is I guess that NIAC will determine that priority, where they see the relative priority of that, and then we'll take that and we'll put an operational plan that covers both the groups that they flagged last week for us and the paediatrics so that we can see how they fit together.
Is there any merit in approaching the booster sequencing by way of when you hit your 5 months, that's when you should get your booster rather than by age? That strikes me as if your immunity wanes after 5 months, that you should get your booster dose on the 5th month.
I'll let Colm come in on that in a second. The only thing I'd say before Colm comes in is that the NIAC set out the priorities based on the clinical risk, and that's what we're following through, but I'll maybe let Colm expand on that.
Vulnerability is age. The vulnerability is age. So Colm, John. Sorry.
Yes, sir. Yeah, I was going to say that the priority is there because of the relative risk increases hugely with age. So rather than the risk of somebody who's 22 comes to 5 or 6 months post their second dose is much smaller than somebody who's age 63, 64. The risk is increases, as we know from our hospitalisation ICU, and hence the prioritisation and the sequence from the beginning has been down through risk groups.
Just in relation to 5 to 12-year-olds, the primary school going population, just reports I've picked up from contact tracers saying that they're kind of flying blind when it comes to knowing the level of transmission that is actually taking place within that group, and that may be school transmitted or household. I take on board what you're saying about the majority of it is household or based in the community. But the idea that we don't actually know, and yet the figures that you're showing us today, the one group that we should be worried about, the graph that's rising at the most worrying rate, or the troubling rise, as you say yourself, is that age group. Are we not flying blind in terms of knowing what actually the level of transmission is when it comes to school-going children?
Well, we know the figures are high, and it's the one the other demographics are going down. But there is an explanation for this, apart from the sequence explanation, which I highlighted earlier, which is that when you look back at the school reopening, it surged for a couple of weeks and then went back down again, and that's because the children come back together. In the 3 weeks that we were doing contact tracing testing in schools, we did an additional 70,000 tests, and they were 1.7% positivity. We know from that information then when children came back together and were at school setting that the positivity of their close contact remained very close for those additional tests that were done. The second issue is, as I outlined earlier, is when you look at the sequence of age group rises, after September the 20th, it was the adult 18 plus that rose first, followed by a lag effect, and then those children aged between 5 and 11 followed after. And that's supported by our public health teams we're seeing. So the third thing I'd say, Simon, is that we've always known, as with any setting, the single biggest driver of infection is community transmission. There's very high 5-day averages now. There's still 4,500 cases or such per day. Inevitably, that will find its way through, of course, to children in households, and will find its way through children into schools, and will, on occasion, find its way transmitting within schools. But the root cause of this is the high number of cases out there in the community.
Just on the administering of the booster doses and then the kind of primary vaccines, hearing anecdotal reports again against this kind of mismatch. In some places, there's kind of vaccinators who are idle waiting for primary dose people to come in, and yet the booster program, we're seeing the queues at City West last weekend. There seems to be this kind of mismatch. Is there a need to kind of look at evening that out a bit in terms of the administration of the booster doses?
I think, Simon, there will always be some alignment geographically, obviously, depending on the age groups you're going through. But broadly speaking, there's a limited number of walk-ins now in the vaccine centres for primary doses, because obviously the number that's unvaccinated is very small. And the other reason is we have the pharmacy sector. We've nearly 500 pharmacies now available throughout the country to do that. So there's a very limited number of clinics been offered for that purpose, to avoid the issue that you've just described. So the capacity, if you like, is focused on the booster within the vaccine centre, because that's where the high volume comes through.
Just a final question from me. There were worrying reports out of Israel this week, and I know they're well ahead of us in terms of boosters, but there was a case of a couple of doctors who were infected. There were breakthrough infections amongst people who had received 3 doses. Have we come across any breakthrough infections amongst people who have received 3 doses, or the 2 plus the booster?
We haven't. Will it happen? Probably. We've known breakthrough infections have always happened. And the greater, I know I'm singing an old tune here, Simon, but the greater number of cases out there in the community, the greater amount of community transmission, the greater likelihood is that you'll see a breakthrough transmission. And we've always said, and we've known, not just in Ireland, right across, that no vaccine, and indeed no booster, is 100% protective. So, but what is really reassuring is the overall, whether that particularly troubling anecdote from Israel, is the overall figures from Israel show a huge drop in serious illness and hospitalisation in those who received the booster vaccine, and that's very promising.
Just for the record, Damian had 215,000 swabs last week. For the last 7 days, it's 223,000. Just for you, so 223,000 PCR lab tests completed.
Are you going to scale up by December?
We've been scaling up to get where we are, and we'll continue to scale up further, yeah.
So the capacity, just on the first slide I had, as Paul said, is 224 is the capacity that's available. Like the actual what's going through week can vary, obviously, every day, depending on the way that's happening, is to be up to 245 by the end of December. And we've used, as I said, a range. Paul referred earlier, Defence Forces, other private providers, our ambulance service, more mobile teams, increasing the staffing in some of the centres. Some of the centres, in fairness to our staff, have offered additional hours in order to expand what's available to do that. So there's a whole range of measures right through the surge plan, and all of this has been planned out. So it's about trying to action those things, I suppose, Dimitri, and get them through. And our plan is to be at that 245 by the end of December. We're allowing for, I suppose, the capacity is one part. How the demand will move will be determined by, the modelling and so on, and where the disease is going. But we're allowing, I suppose, we have the capacity available. That's the key thing. Although, as Paul said, ultimately it isn't elastic, and referred to home care, the challenges in staffing, our hospitals, vaccinations. There's a whole range of demands on health and social care staff. So there will ultimately be limitations at the same time in terms of where we go to.
I know you mentioned Simon's question about the boosters for the children, or the first dose for children. Are you able to start that as soon as NIAC makes an announcement on that? You're ready to go? It can be rolled out quite quickly. Is that the plan?
So there's 2 things. One is NIAC recommend the actual administration in the first instance. That isn't there yet. Secondly, that it'll determine the priority. So the sequence in which it will follow on with the other groups will be based on the priority NIAC give it to us. What we're working through in the preliminary planning I mentioned on the slide is all the elements then that are needed to operationalise that. The IT system changes, the communications plans, consultation with parents in terms of any information they may need, and so on. All of the elements, plus as well one critical point in terms of delivery. If we administer a dose 1, this is not like the booster. We've got to make sure we have the vaccine in 21 days to give the dose 2. So there's a range of things that will determine what that plan looks like for paediatrics.
Hi, just to start, Paul, you said last week that there were quite high rates of no-shows for booster appointments. Has there been any improvement since then?
Yeah, we've seen strong improvements overall. We've put some, and Damian can brief, we've put some changes, modifications in for people to notify us if they can't make a particular appointment on our site, hsc.ie. But ultimately we've seen, and as you've seen from the walk-ins, strong presentations from walk-ins, but ultimately much stronger. And I think the public have really embraced now the booster programme. And it's probably like what we've seen at the start of the vaccination programme overall. And we've scaled up our resources as well. So yeah, strong improvements in attendance levels overall.
It's possible maybe just to give a bit of detail on that. Last week you'd said that you were seeing no-show rates of between 25 and 50% at certain centres. What are the highest kind of no-show rates that are being seen now?
It's dropped. I wouldn't have the exact percentages, but we know from feedback from the sites, like it does vary depending on what the clinic is that's running on a given day. You know, is it for healthcare workers over 60s? Is it a dose one? So it's dropped off certainly this week in the sense of we're seeing better attendance, but it's still a challenge. But as Paul said, what we've done is we've adjusted the model to also offer walk-ins to people to try and maximise the throughput in the centres so that we're getting more people boosted earlier. So it means we're over-scheduling, not dissimilar to the way airlines sometimes operate in terms of overbooking systems, and also then in terms of the walk-ins, but they are structured walk-ins. So we don't want to have 500,000 people in a certain cohort suddenly turn up at a centre. So we're trying to manage them such that we have a certain proportion of those done or only a certain percentage are eligible so that we can manage that. Now, clearly there were some pressures in City West over the weekend in relation to that. And obviously we've put improvements in place. City West have put some improvements even between the Saturday and the Sunday to try and ensure that was a little bit smoother. But the reality of walk-in clinics, when you have large numbers of people who are waiting to be vaccinated, is there will always be an element of queues. And we'll try and manage that as best we can to minimise that for people, both in terms of their experience when they get there, but also in terms of trying to ensure from a planning perspective the numbers that might avail of it. So if we give an example to reinforce that in terms of the medically vulnerable, we'll be prioritising appointments for those over the coming weeks for obvious reasons. One is there's a huge cohort there and we need to get through it. And secondly is we don't want people who are medically vulnerable queuing in early stages. But as we move through it, if we feel that the flexibility of walk-ins, because it does suit lots of people, you know, in terms of that flexibility, in terms of the hours of attendance, we'll look at that as we go through it for each group.
Colin, was just yourself, I think, talking about how vaccines have saved 9,000 lives, presumably since they've started being used here. Could you just give a bit of detail around how exactly that was worked out?
That's the EU Commission report. They looked at the vaccine programme and uptake in each country and marked it against the estimated lives saved over a certain age, and that was the figure they arrived at for Ireland, where we had, of course, the highest vaccine uptake in Europe.
So, I suppose just in terms of how that works, does that just look at vaccine uptake versus expected cases, or like how exactly does that work? Like,
well,
how is it calculated?
the methodology is looking at the uptake versus the effectiveness of the vaccine, versus particularly its effectiveness in reducing serious illness, hospitalizations, ICUs, but in this case deaths. So it's the estimated. And we know the effectiveness of the vaccines to date has been particularly marked in terms of serious illness, which goes right through from hospitalisation right up to death.
Example that Emer Cook, from the director of the EMA, mentioned this week. She compared Ireland with a 93.5% take-up with two other EU countries that have 50% take-up. We had 50 in the past 14-day, in a 14-day period, 15 deaths per million, and they had 260 deaths per million, so 16 times more by less vaccination uptake.
Just finally, briefly going back to the question of schools, obviously been quite controversial the past week or so, and colleagues in NEFIT were asked about it yesterday. Both the CMO and Deputy CMO said that they thought why there's, or at least a large contributing factor of why there have been so many cases among school-going children is because that cohort hasn't been vaccinated at all. Is that a reason that you think as well is what's driving cases among children?
Common detail on children and the knowledge there, but just even the point I made in my own presentation around adults not vaccinated. Look at the high impact of hospitalizations and ICU and adults. So the virus is obviously, and we know by evidence, goes to the weakest point, which are unvaccinated people. So Column can accommodate children, but just even in adults alone, 48% of the hospital cases today are unvaccinated. 50% of the people in ICU are unvaccinated. 79% of the people hospitalised between the ages of 19 to 45 are unvaccinated. So, it does go to the point of weakness. Colin can comment on you.
It will go down the path of least resistance. So the whole spectrum of illness, from infection, which may be asymptomatic or mildly asymptomatic, unfortunately, for the great majority of children, is either they're not ill at all or have minor illness, right through to people who are hospitalised in ICU. The virus is finding its way through to the unvaccinated population, because that's the path of least resistance at the moment. As I said, it's fortunate for children that for the great majority of children, it's not a serious illness. But if the numbers go high enough, eventually you do, as we saw in January, we began to see reports of younger people admitted to ICUs. It wasn't necessarily because the Delta variant was any more adept at attacking younger people. It was because if enough people get sick or acquire the virus, then eventually somebody without an underlying condition is going to become sick.
I suppose just on the point of vaccinations, a couple of people have raised the question that if it was known, or at least very strongly suspected, that there'd be more cases in unvaccinated groups, so why was contact tracing removed when children, or shortly after when children returned to school?
The contact tracing, let's look at the purpose of the contact tracing. The contact tracing involved taking children out of a school setting, disrupting the continuity of their education, and all for a cohort of the population for whom the virus presented a very minimal risk, a very low risk indeed. So if you remember back to September, there were thousands of children, because of the rules that went to contact tracing, who had to go into isolation to be tested and whose education was disrupted for a huge cost to them, because the virus presented a very low risk to them. And as I said earlier in response to one of your colleagues' questions, that when we were testing contacts at that time, we did 70,000 extra tests in those first 3 weeks, and the positivity of those 70,000 tests was 1.7%. So our experience at the time was that contact tracing and testing those close contacts in what is a relatively controlled setting compared to household yielded a very low positivity rate, and ended up in disrupting the education and opportunities and experience of many primary school children. And it was for this reason, based on public health advice, not just focused on COVID alone, but focused on the entire needs of children and what presented the balance of risks and benefits to them, that it was in their greater interests to continue their education and not see it repeatedly disrupted.
I mean, would that logic not still apply now? And obviously contact tracing has been reinstated.
And if contact tracing, I don't understand the question. Perhaps you could.
Sorry, that point about contact tracing in schools being very disruptive for children, presumably that still stands, and I think the contact tracing has been resumed in schools.
It's that, the point I was making, to restate it, is that the effect of contact tracing was to disrupt the education. I think at one stage there were 10,000 children per week, I can't remember the exact figure, who had to go home, and yet who in a large part were asymptomatic or had a very low positivity when we were doing close contact testing. So the net benefit to them was actually very, very minimum, but the net harm to them was huge in terms of having to go home, stay in isolation, getting tested, and a very low positivity of the test.
Hi, Niamh Griffin from the Irish Examiner. Damian, can I start with you? The type of vaccine that's been used for the boosters, is that right that it's been changed to only Moderna from this weekend?
Pfizer and Moderna, so both vaccines are equal, both are recommended, and we use both vaccines. We manage, I suppose, the supply of both vaccines in terms of expiry, so we try and utilise those across the centres. So both vaccines are recommended by NIAC. And that's what we use across it. So we've used both vaccines and continue to do that. And we have stock for both, and we'll continue to maximise the stock. Any guidance that we give out to the centres is predominantly based in relation to expiry, that we'd make more use of Moderna or more use of Pfizer at different stages based on what's available. But both vaccines are equal, both are recommended, both are equally positive in relation to the impact from in terms of the vaccine for boosters.
So if people go to the centres this weekend, they should expect either Moderna or Pfizer, and there's no option to choose, is there? For
just to be clear, I suppose we've never had vaccine choice. Both vaccines are recommended for use. Need to be crystal clear on that. And we deploy the vaccines to the centres, both in terms of GPs, pharmacies, and the vaccine centres, based on managing the stock across both. But both vaccines are equally strong. Both are recommended, and people will get an offer for a vaccine for either or, depending on what's been used at that time. And it may be more of one or another in a particular setting at a point in time.
Okay. And in terms of the vaccines for children, do you know when they'll be delivered to Ireland?
We have some indicative dates, but we don't have exact dates yet. So we believe one may come around the third week in December and some in January. And we're finalising those sort of dates with Pfizer at the moment in terms of the exact availability.
Okay, thank you. And could I just ask you about you mentioned the shortage of carers. The HSE in Cork and Kerry said they're about 21% down. Would that figure be reflective across other parts of the country?
Unfortunately, there are many areas now that are at that level in terms of shortage, and we're working to see how we can improve that situation. We have a new approach in terms of an internship type model for carers. We find people who are applying for roles as carers don't have the necessary training qualifications, so we're looking at that in terms of the FETAC level 5 training that we need, and also supporting people. There's unfortunately a bit of a misunderstanding at times about what the role of a carer is. And we're trying to encourage people to come forward for those roles. But it is a significant challenge in many areas. As I said, it used to be confined to just a couple of parts of the country, but now it's much more widely spread.
Okay.
Zara King, Virgin Media. I suppose the takeaway from both the HSE this week and the CMO yesterday is that, yes, while things are stable, they're still far too high. I think you said it before, Paul, that there's really nothing normal about what we're seeing right now. Have you a target number in mind in terms of what the hospitalisations need to come back to in terms of getting to a manageable sort of level? Is there a target figure in mind? So over 500 at the moment, could you manage with 200, for example, or what sort of numbers would you be thinking?
I think the reality of it is we're managing with the numbers we have, but it's having an impact on other healthcare and particularly elective care. So there's not a magic definitive number where we say we're okay. Having anybody in ICU COVID positive is one too many, having any one person, because this is, as we've been saying, a disease we can all work to prevent. So, and it does impact. And any number in hospital, even a lower number, if it was 100, it has a highly disproportionate impact on our health system because we have to isolate, we have to close down wards. So, any number has a highly disproportionate impact, and that will inform, the levels of, I guess, public health actions that we all have to continuously take. So there's no one definitive number. Thankfully, what I would say for this week, we've certainly seen a stabilisation. And as you just described yourself, it's a stabilisation at a very high level. Should this turn again at a period that we know is high risk, around Christmas, this could be a really difficult winter for us, along with the flu and along with the unknown of the Omicron.
And then of the 6% of people who remain unvaccinated, do we know how many of those have contracted COVID-19 and recovered in the last 6 months, thus having some level of immunity? Do we have any stats on that?
Breakdown of the numbers within, as you say, the last 6.5% who haven't been vaccinated. What we do know is those numbers their recovery level. What we do know is there's a higher proportion and a higher potential for those people who are unvaccinated to end up in ICU, for them firstly to end up in hospital and secondly to end up in ICU. And this is not, my message today is not to put a blame, it's to simply describe, and our consultants and our hospitals and doctors would ask us to say this regularly, it has a high impact by people not being vaccinated on our health system. And that's what they ask me to say as strongly as we possibly can. It has a high impact on our ICUs for those people. And this is something that people can take the levels of protection from protect themselves, protect their family, protect society, and protect the health system. And I've been urged to say this as strongly and regularly as we can. Very positively last week, 10,000 people came forward for their dose 1s, 10,000 people came forward for their dose 2s. So we're continuously seeing people coming through and registering over the last 3 days, again, in particular, high numbers are registering. So, we are there. We're continuously, as Damian said, focusing on, it's not one single group in the remaining 6.5%, but as much focus as we need to put on the boosters, we want to make sure we're putting as much focus on our communications on those remaining 6.5% as well, of adults.
I suppose, look, we do just hear so much about unvaccinated people ending up in hospital. I suppose, do you think maybe it is important for us to understand how many of those are moving forward, particularly in the next 6 months, with some level of immunity? If they're not going to get vaccinated, at least we need to understand how many of them are in some way protected. Do you keep an eye on those numbers?
We do across the board, but I'm not quite sure there's a theme of a difference between, I don't have the details, I have the facts, but I think the message has to remain. If you're unvaccinated, you have a much higher potential, as Colin has outlined it, to end up in hospital. And if you're unvaccinated, you have an extremely much higher potential of ending up in ICU.
Damian, can I just ask you, obviously the Omicron whole genome sequencing is ongoing. I was actually in the NVRL yesterday chatting to some of the team that are working on it. I'm just wondering, how long do we keep, I presume we only keep positive samples, we're not going to keep negative. So we obviously store the positive samples. What percentage of positive samples do we keep? And how long do we keep them for? So how far back can we go if we need to pluck a sample from? Is it 3 weeks? Is it 6 weeks? What's a reasonable time that we keep these samples for? Obviously, there's thousands of them, so we're hardly keeping all of them. But what kind of numbers are we keeping?
They're kept for a very short period. I can't give you the exact details, Zara. We can come back to you on that in terms of the actual date, but I know it's a relatively short period for the reasons you're set out in terms of the value. And I understand from Killian de Gascoigne as well, there's also deterioration, if you like, in terms of the sample, in terms of its efficacy, I suppose, for use. But we'll maybe come back to you separately on that. I don't have that exact date to hand, but it's relatively short.
And just, I know yesterday, in fairness, you got back to me just about that glitch in the system with the text messages. Can you just explain, you might have said it earlier, just exactly what happened and what impact did it have? Did it end up that a lot of people did miss appointments for testing yesterday because of it? I know it went on for a couple of hours.
So there was a problem with our texting provider, and in fairness to our IT team and the texting provider, they got it back within a short period of time. So those people who would have had text delayed, those were subsequently issued, and then obviously prospectively there was an issue there in terms of making sure that was sorted out. So it was sorted out relatively quickly. Within about, I think, 2 to 3 hours, the problem was resolved.
Colin an scale faoi Omicron, Dr. Henry.
Well, it's cúis imní doing gohfuil an tarraic uair seo anis agin agus tá is tá lán gréthe modulation an ahraic seo níl sé rólas agin go fóil ach tá na saineolaí ar fud an dóin ag Janú Fistracham níos idir an céco tulgachas atá sé agus céco mór an bhfuil a héanis maidir a galar agus de lehéidí. So for láthair cosúlas tíorhéil ar fud an dóin tá muid ag cur costin sa bhreis I bhaim sa dóis go muid abalta an teachtasteach an tarraic seo muile chur ar chógas is féidir agus sin an strateiste aginné agus na tíortha ilí gur fud na Eorpa for láthair.
Quick question for you. A couple of weeks ago, you said staff absences, people, presenting with COVID symptoms have to go home or being ill, was having a big impact on the health, adding to the pressures. Do we have updated figures about, has that stabilised? Has it got better since the boosters? Is it still having a problem with overall care?
Yeah, we still have a lot of people out. So the number we haven't got an updated figure from last week because we do that national count every second week. So it's still, I think, 5,300 was the figure from last week with cocooners as well. So it was having an impact. We don't have any evidence yet to say that it's come down, but I don't have updated figures nationally.
It's adding to the pressure, certainly.
Oh, completely, yes. And our staff absence is a huge challenge for us, and we have certain facilities where there's a particularly high level. So if you look, for example, the Mater Hospital had very significant challenges last week in terms of staff absence. So it is very much a real pressure. And bear in mind that is on top of our normal 4% absence rate. So it is definitely a challenge for us across the board in terms of having sufficient staff to cover all bases. And just when we're talking about the pressures on systems, as Damian mentioned, the testing service puts a huge pressure on our community services that's run through our CHO. So it all plays off each other, but staff, the lack of staff in certain services is a problem.
One last question for you, Paul Reid. 2 weeks ago, you described the pressures on the health system as grim and the outlook was pessimistic. What would you say the outlook is now? How would you describe it over the past week?
Stabilised, but still a high risk, and particularly a high risk as we head into December, Christmas period, and New Year. So I'd say we are still on alert in terms of the impact it's having on the health system, all across the health system, not just hospitals, but our, as Anna's described, our community services too, our GPs. So we go into December on high alert. Well, I mean, there's relativity of grim actually in fairness, but the reality for us is all of our healthcare staff all across the board are under massive pressures. We're trying to resource up everything. GPs themselves are trying to resource up supports. We're trying to resource up our hospitals. We're trying to resource up our ICUs. We're trying to resource up testing and tracing, our community teams. We're trying to resource up boosters and vaccination programs. So it's a health system under significant pressure still.
Sorry, one last follow-up from me. Colm, I know what you're saying about in terms of the contact tracing in schools, the 70,000 extra tests in the early days and showing the positivity level of 1.7. And I hear you on the harm from missed education is greater than the benefit from the contact tracing and the isolating that would come from that. But have things not changed since then? Your own figures show that the rate of increase is more than twice the level for the 0 to 18s than any other age group. And the fact that there's 12,000 new cases amongst 5 to 12-year-olds in the last 2 weeks of November. The point you're making is somewhat historical. The current point is that the virus is circulating quite rapidly amongst the largest unprotected, unvaccinated cohort in the population. Does that not merit the argument for reintroducing contact tracing of some kind in schools again to get a picture of what's going on in there?
Just 2 points in that. First of all, it's important for us all to remember that we have, if anything, over ascertainment in children, because as you know, close contacts who are vaccinated don't have to get tested. So we're seeing extraordinary levels of testing among children, and not the same level among adults. So certainly the cases have gone up in children, but there's and that includes the great majority of those are asymptomatic or mildly symptomatic. Unfortunately, as I said, it doesn't have any serious consequences for children. So there is, our public health experts tell us there's what they call over ascertainment. In other words, that we're picking up cases because we're testing children in every setting because they're not vaccinated, while adults were not, because those who are vaccinated either don't have to get tested or in a household setting get the 3 antigen tests. The second point is, just to revert to what I said, Simon, earlier, is that, of course, when levels get so high, it is a threat to education, it's a threat to children if numbers get high enough. But the root cause of that is the level of community transmission. And people can argue whether or not contact tracing needs to be reintroduced in schools. But there's an element of futility about it when there's such widespread number of cases out there in the community, 4,500 cases per day, and possibly many more that we're not aware of.
Yeah, my question is just for yourself, and just in relation to the launch of the bereavement resource. So I'm just kind of wondering, a lot of positive feedback on that from people online, particularly families who've lost loved ones to COVID in the last 2 years. What exactly will be different in terms of what other resources the HC would have had previously for bereavement? What's new about this and what's being launched that's new?
We have the bereavement support line run by the Irish Hospice Foundation that'll operate from 10 to 1 Monday to Friday. And that's really important. So there's also a range of resources on our HSE website. I think part of the problem about grief and bereavement is that it's often misunderstood. So there's no pro forma way to grieve, and for people to understand that, and there's resources available on our website, and we're going to be working with our partner agencies in relation to disseminating communications information and that, but to check out the website and also access the support line for people who feel they need that bit of extra support.
Just a quick one for yourself, Colm, to follow up on Simon's point. I suppose a lot of people might ask, you're saying that there's just not really a point in terms of reintroducing contact tracing because of the levels of community transmission. Some people might ask, what's kind of the difference in that? When you talk about community transmission, surely people are picking it up, they pick it up in workplaces or shops or whatever. So when you're talking about community transmission, you're really talking about transmission in these settings, and surely a school is also one of these settings where transmission takes place.
Absolutely, and just to be clear about this, I'm not. I can understand how much worry and concern this causes for parents, for teachers, for children. And what I'm trying to explain is that in any system of care, whether it's testing or whether it's the work of public health departments, there's a prioritisation, and the prioritisation clearly for public health teams and for contact tracing is in those settings there's the potential to cause the greatest harm, and they remain those settings that we've learned the hard way over the past almost 2 years now. Healthcare settings, nursery homes, residential care settings, workplace settings, settings where there's congregated adults with vulnerable underlying conditions. These are the vulnerable settings. These are the areas where the work of public health teams and contact tracing is most effective, because you're trying to prevent outbreaks, you're trying to reduce transmission. Of course, transmission can occur in a school setting. Our experience of our public health teams is, for the large part, children are acquiring it in household settings rather than acquiring it in school settings, and that school settings are not incubators, which act as a significant source of outbreaks going out into the community. That's the experience, not just in this country, but right across Europe.
Ian Neve from the Irish Examiner again. Just on the vaccines, there was an audit underway, I think, on the vaccines to see whether doses were coming up to be out of date. Do you know if that's going to be published, or is it available?
Yeah, I think that, I'm not sure where the term audit was used, maybe even used it ourselves, but effectively we look at that every single week. So we know what the supply line is, and we move the vaccines then based on that. So we're always making sure, I suppose, that we don't get anywhere close to expiry. And I think I mentioned previously, then the other thing that we also keep an eye on is if we have surplus vaccines, like we did with Uganda, we look at repatriation, working with the Department of Health where that might be needed. That's not a factor at the moment, given the scale of the booster program that's there, but that's something that we manage even on a weekly basis. There isn't a sort of a one-off audit process. It's dynamically managed every single week in terms of what the profile is.
And just one last question. The cyber attack, the consultancy report, do you know when that might be published, Paul, maybe?
We're just in the final stages with the consultants on our board in terms of closing out on the recommendations. So, it's imminent, it'll be soon, but we're still closing out final stages of the report prior to publication. Yeah, we'll be aiming as soon as possible to issue it once we finalise it.
Everybody happy? In which case, thank you very much, and see you next week.